Welcome to Podocyte Talk. In this episode, we explore three impactful studies that reflect the broad landscape of contemporary nephrology, intersecting with cardiology, immunology, and transplant medicine. These studies underscore the importance of early risk detection, individualized treatment strategies, and long-term outcome monitoring across diverse patient populations. We begin with a post-hoc analysis from the ASPREE trial that investigated whether the presence of albumin in urine, even at low levels, could predict the development of atrial fibrillation in older adults who were otherwise healthy. The original ASPREE trial enrolled community-dwelling individuals aged 70 years and above, with no prior history of cardiovascular disease, dementia, or significant disability. In this analysis, over 19,000 participants were followed for nearly 5 years, during which annual measurements of urine albumin to creatinine ratio were taken. At baseline, participants had very low levels of albuminuria, averaging just above 2 milligrams per millimole. Yet the study found a significant association between elevated albumin levels and incident atrial fibrillation. Individuals with a urine albumin to creatinine ratio of 3 milligrams per millimole or higher had a higher rate of developing atrial fibrillation compared to those with lower levels. The relationship remained consistent even after adjusting for other factors such as blood pressure, diabetes, and kidney function. A doubling of the urine albumin level was associated with a meaningful increase in atrial fibrillation risk. These findings suggest that even low levels of urinary albumin may reflect underlying vascular injury or endothelial dysfunction. Albuminuria may serve as an early marker of systemic stress, highlighting cardiovascular vulnerability in older adults who might otherwise appear low risk. Shifting from risk prediction to treatment outcomes, our second study focused on the long-term impact of rituximab therapy in adults with membranous nephropathy, which commonly presents as nephrotic syndrome in this population. This retrospective analysis included 159 adult patients treated with rituximab over a 22-year period. The median age was 58 years, and most patients were male and of white ethnicity. At the time of treatment, patients presented with significant disease burden. Median daily proteinuria exceeded 9 grams. Blood albumin levels were around 2.7 grams per deciliter, and kidney function was moderately impaired, with estimated filtration rates around 55 milliliters per minute per 1.73 square meters of body surface area. About 3/4 of the patients tested positive for antibodies against the M-type phospholipase A2 receptor, which is associated with an autoimmune form of membranous nephropathy. Following rituximab therapy, 88% of patients achieved either partial or complete remission. Partial remissions occurred within a median of 7 months, while complete remissions typically took around 23 months. Immunologic remission, defined as disappearance of the phospholipase A2 receptor antibodies, was also observed in most of these patients. A small subset, about 12%, failed to respond. Prior use of other immunosuppressive medications and greater degrees of chronic damage on kidney biopsy, such as interstitial fibrosis or tubular atrophy, were associated with non-response. Over a median follow-up of more than 5 years, only 7 patients progressed to end-stage kidney disease. The long-term kidney survival exceeded 95% at 10 years, comparing favorably to historical outcomes with regimens like corticosteroids and cyclophosphamide. This study reinforces that rituximab offers not only disease control, but durable renal preservation in membranous nephropathy, particularly when used before advanced structural damage occurs. Our final study turns to the transplant setting, examining how pulmonary pressure prior to kidney transplantation influences outcomes after the procedure. While pulmonary hypertension is known to be common in dialysis patients, its prognostic value post-transplant is less well understood. This retrospective cohort study included over 5,300 kidney transplant recipients from 3 major centers in the United States between 2011 and 2021. Pulmonary hypertension was defined using transthoracic echocardiography as a right ventricular systolic pressure of 35 millimeters of mercury or higher, a threshold commonly used in clinical practice. Approximately 1/3 of recipients had elevated pulmonary pressures prior to transplant. Compared with patients who had normal pressures, those with pulmonary hypertension had higher risks of post-transplant mortality, allograft failure, and graft loss independent of patient death. Moreover, these risks increased progressively with higher pulmonary pressures, indicating a possible dose-response relationship. The study suggests that even when assessed non-invasively, pulmonary hypertension provides important prognostic information that should be factored into the pre-transplant evaluation process. Identifying transplant candidates with elevated pulmonary pressure could allow for closer monitoring, earlier intervention, and potentially modified immunosuppressive strategies in the post-transplant period. Together, these 3 studies demonstrate how nephrology practice is evolving, highlighting the presence of albumin in urine, even at low levels, as a potential early signal of cardiovascular risk. The use of rituximab as an effective and durable therapy for membranous nephropathy, with favorable long-term kidney outcomes, and the recognition that elevated pulmonary pressures before kidney transplantation are associated with worse post-transplant outcomes and warrant greater clinical attention. Thanks for joining us on Podocyte Talk. Be sure to check the episode description for links to the full studies, and stay tuned for future episodes as we continue to highlight cutting-edge research shaping the future of kidney care.